Hello, and welcome to our webinar today, Using MMPI-3 Comparison Groups. Our presenter today is Dr. Ben Porath. Dr. Ben Porath is a professor of psychological sciences at Kent State University and a board-certified clinical psychologist. He received his doctoral training at the University of Minnesota and has been involved extensively in MMPI research for the past 38 years. Dr. Ben Porath is a co-developer of the MMPI-3, MMPI-2RF, and the MMPI-8RF, and co-author of numerous test manuals, books, book chapters, and articles on the MMPI instruments. He has served as editor-in-chief of the Journals of Psychological Assessment and Assessment, and is a member of APA's Committee on Psychological Tests and Assessment. Dr. Ben Porath's clinical practice involves supervision of assessments at Kent State's Psychological Clinic and consultation to agencies that screen candidates for public safety positions. He also provides consultation and expert witness services in forensic cases. We are extremely pleased to have him here today to share his expertise with us. So please take it away.
Thank you very much, Ben, and good day, everyone. Welcome to our webinar on using MMPI-3 comparison groups. Before turning to the substance of the presentation, I would like to offer a disclosure of my financial interest in the MMPI instruments. I am a paid consultant to the MMPI publisher, the University of Minnesota Press. I also receive research funding from the University of Minnesota Press, and as co-author of the MMPI-2RF and MMPI-3, I receive royalties on sales of test materials and scorings. With that, we'll go over our agenda for today's presentation. I'm going to begin with a little bit of background talking about comparison groups, when we started using them and how they're used, and then move on to a discussion of our currently available comparison groups for the MMPI-3. We're going to take a look at some of those comparison groups, and then go through a series of case examples illustrating use of comparison groups with the MMPI-3. And at the end, we'll have some questions and answers. So with that, we'll turn to the background. Comparison groups, as they're currently used with the MMPI-3, were first introduced with the publication in 2008 of the MMPI-2RF. These comparison groups, the comparison group data, are intended to complement information that is available from the test norms. So when we, of course, look at T-scores, these are based on the general population. When we use the term norms, we're referring to the standard scores that are indicate the test taker's standing on the scale of the MMPI-2RF, or now the 3, in reference to the general population, to our normative sample that is intended to represent the general adult population of the United States, or wherever the comparison group may be from. So, of course, that's the primary vehicle for interpreting scores on the MMPI, is by looking at the T-scores and following the interpretive guidance in the test manual for identifying empirical correlates associated with various T-score levels, for example, on the MMPI-3. Now, comparison groups and comparison group data are used in order to complement information from the test norms and tell us not only how the individual's scores compare with the general population, which is what the T-score tells us, but also how the individual compares with a representative sample of individuals tested in a similar setting or under similar circumstances. And we'll get into the specific types of comparison groups that are available here in a moment. So again, this is complementary information. Sometimes you'll hear or see people referring to these comparison group data as norms, for example, police norms. But we, with the MMPI, prefer to use the norms strictly in reference to the general normative sample, the general population sample, and any other setting or setting for which we have comparison groups, we use that term, comparison group data, rather than norms with the MMPI. So when the MMPI-2RF was first introduced in 2008, we included these comparison groups that are listed here in the slide. You can see, for example, that we had comparison groups representing either the men or the women. When it says men and women, that means there was a separate comparison group for men and a separate comparison group for women of the MMPI-2 normative sample. And that was done because beginning with the MMPI-2RF, the norms, the T-scores are non-gender. We don't have separate T-scores for men and for women on the MMPI-3, nor did we have them on the MMPI-2RF. The norms are based on a combined gender sample, equal number of individuals identifying as men and as women. But if there is a need or an interest in comparing a test taker's scores with just the men or just those identifying as women in the normative sample, then that can be done via the comparison groups. We also had a couple of mental health outpatient comparison groups, one a community mental health center and the other from independent private practice. Again, separate comparison groups for men and for women. A couple of psychiatric inpatient samples, one from a community hospital, the other from a VA facility. And for that sample, there was only a sufficient number of men to create a comparison group. Also a VA sample of men entering substance abuse treatment, a sample of bariatric surgery candidates. We, again, at that point, when the test was released in 2008, only had data for women, bariatric surgery candidates, college counseling clinics, so college students receiving services at a mental health counseling clinic at universities or undergraduate institutions. Also a general college student sample, a couple of forensic samples, one made up of disability claimants, the other a sample of pretrial criminal defendants, prison inmate samples separate for men and for women, and then two personnel screening or pre-employment evaluation samples, one for law enforcement officers or police candidates, and the other for candidates for correction officer positions. These were combined gender comparison groups, so we didn't have separate comparison groups in these pre-employment samples for separate for men and for women because of prohibitions in the law, federal law, against use of gender-based norms and employment-related testing. So for any comparison group that's intended for use in an employment context, we only have combined gender equal number of men and women in the comparison groups. So that was the list of comparison groups when the test was first released in 2008. This is the final list of comparison groups for the MMPI-2RF. We're no longer adding comparison groups now that the MMPI-3 is available for use. But what you can see here in red on these slides are all the comparison groups that were added after the initial release of the MMPI-2RF, because this is an ongoing process. And as we'll talk in just a little bit with respect to the MMPI-3, that's also the case with the MMPI-3. We are still constantly adding and will continue to add comparison groups moving forward. But as you can see, we added a number of samples, men entering a sexual addiction treatment program. We added a sample of male bariatric surgery candidates, spine surgery and spinal cord stimulator implant candidates, individuals in chronic pain treatment programs, a sample of individuals undergoing forensic neuropsychological examinations, two additional forensic samples of child custody litigants and parental fitness evaluees, a sample of sex offenders, and two additional pre-employment samples for clergy candidates and for firefighter candidates. So again, this is our final list of comparison groups for the MMPI-2RF. Now, part of the planning for the MMPI-3, which for the development of the MMPI-3, which took part in the late teens, involved collection of data for new comparison groups. And this was necessary because the MMPI-3, of course, includes new items, and so we're not able to use any existing, we were not going to be able to use any existing data sets to create comparison groups for the MMPI-3. And so part of the planning for developing the test was to collect new comparison group data. So field data collection was just one aspect of the development of the MMPI-3. Data were collected in a number of sites representing settings in which the MMPI is used, including mental health settings, medical settings, forensic, and public safety. Some of these data were used for scale development and validation analyses, but we also, again, intended for these data to be used to develop comparison groups for the MMPI-3. The field data collection wound up with roughly 16,600 protocols. You can see that a fairly large number of them came from public safety settings, and that's because we were planning to develop comparison groups for 4 different occupations, candidates for police officer positions, correctional officer positions, firefighters, and dispatchers. We also collected data for individuals receiving services in mental health settings, medical settings, forensic and correctional settings, disability claimants, and a general community sample. And these data were then used to compose the comparison groups that were available when the MMPI-3 was released in late 2020, in November of 2020. So as you can see, we again created comparison groups that allow us to compare a test taker's scores with just the men or just the women of the normative sample, a couple of mental health outpatient samples, college counseling clinic. At the time, we only had a sufficient number of individuals. And I should mention that a comparison group is composed of at least 200 valid protocols. That's the minimal number of cases to create a comparison group. So when the MMPI-3 was released, we had a sufficient number for college counseling women, but not men, a sample of individuals in sexual addiction treatment, spine surgery and spinal cord stimulator candidates, forensic disability claimants. So as you can see, the list is fairly comparable or similar to, not identical to, the list that we had when the MMPI-2RF was first released. Several pre-employment evaluation samples, college student sample. And then, of course, with the MMPI-3, we have separate norms for the Spanish language version of the test for the first time. We did not have Spanish language norms for previous versions of the MMPI. And so with the Spanish language normative sample, again, it's a non-gendered sample made up of individuals identifying as men and women, equal number, but it is possible to compare a test taker's results with just the men or just the women of the Spanish language normative sample for the MMPI-3. So again, this is our list that was available in 2020, late 2020, when the test was released. And we're going to turn next to our currently available comparison groups for the MMPI-3. As you can see on this slide, the list is quite a bit longer. We're, as I mentioned, regularly adding comparison groups to the scoring software. And I've color-coded the comparison group list here. All of the ones in red are comparison groups that were added prior to the most recent release to the scoring software. And what you can see is that for many of our samples, we've added combined gender comparison groups. This was done in order to make it possible to use comparison groups without specifying gender, because of course some individuals are non-binary and do not identify with either men or as women. And in those instances, it's now possible to use the combined gender comparison groups that are available for most of our settings. It's not necessary when you score an MMPI-3 to specify gender, because we use non-gendered norms. So this allows us now to also not need to specify gender for using comparison groups. We also have added already in the past a sample of clinical neuropsychology evaluees. So these are evaluees undergoing neuropsychological assessments in a clinical context, not a forensic one. We've added bariatric surgery candidate samples, male, female, and combined gender, and added that male college counseling sample that we did not have when the test was first released. We've also added female and combined gender prison inmate samples, as well as firefighter candidates. And then the ones listed in orange are those that were just recently added to the scoring software to Q Global. As we'll see, any of these can be used when producing a score report or an interpretive report. And so the most recent additions include VA Medical Center outpatient males, sample of collegiate athletes, 2 new forensic samples, child custody litigants, and parental fitness evaluees, a sample of airline pilot candidates, and clergy candidates. Listed in blue are 2 additional comparison groups that are available for use outside the U.S., with community samples representing the adult populations of Australia and New Zealand. And as you can see at the bottom here, we've added to our Spanish language comparison groups a sample of parental fitness evaluees who were assessed in the context of a parental fitness evaluation in Spanish. And in Puerto Rico, we have at this point female and combined gender comparison groups. We're still accumulating cases to also add in the future a male comparison group to go along with the other 2. So again, as I mentioned, this is an ongoing process. We'll talk at the end about some future directions with comparison groups, but this is the list of currently, as of this recording, available MMPI-3 comparison groups. So let's take a look at some of these comparison groups and see what they tell us about how various groups compare with a general normative sample of the MMPI-3. And we're going to start actually with the MMPI-3 normative sample. So this is a sample, of course, made up of 810 men and 810 women to calculate the T-scores, or to derive the T-scores for the MMPI-3. We combined these 2 subgroups into one sample. We call it the non-gendered normative sample of 1,620 individuals. But as I mentioned, if there is a need or interest in comparing a test taker's scores with just the men or just the women of the normative sample, it's possible to do that with the scoring software for the test. And what we see here is the breakdown, or what we're plotting are the mean scores. We're also reporting the standard deviations here at the bottom of this chart for the men and women. And as you can see on the validity scales, they're quite comparable to each other. Generally speaking, a T-score, a difference between 2 samples, has to reach at least 5, the value of 5 T-score point difference, for it to be clinically meaningful. And as you'll see when we go through these next slides, none of the differences reach that level between men and women, those identifying as men and women in the MMPI normative sample, with one exception that we'll see at the end. So these are scores on the higher order and restructured clinical scales. And again, we do see very moderate differences, 4-point differences, with men scoring a little bit higher than women on some of the externalizing scales, the behavioral externalizing dysfunction and RC4 antisocial behavior. But these fall below that threshold for beginning to look at differences as representing or being clinically meaningful. Same result with our somatic and cognitive scales. Here we see a 4-point difference with the women scoring higher than men on anxiety-related experiences in the normative sample. And looking at the externalizing scales and interpersonal scales, again, much more similarity. And of course, the standard deviations are going to be at or about 10 because this is the normative sample. And so this is the sample that was used to derive T-scores, which for the combined gender sample all have a mean of 50 and a standard deviation of 10. And then finally, this is the one exception where we see a difference of 6 T-score points between men and women on the disconstraint scale. This is a very well known phenomenon. We had the same phenomenon or the same difference on the MMPI-2RF, not only with the normative sample, but many of our comparison groups, men fairly consistently score higher than women on the disconstraint scale. And again, using a comparison group gives us that additional perspective. We'll talk a little bit more about what to make of that, such differences later in the presentation. Okay, so that's our normative sample for the MMPI-3. We'll take a look now at outpatient community mental health, our two outpatient community mental health samples, the men and women. As you can see, we have 233 data for 233 men and 356 women. All completed the MMPI-3 as part of the intake process for treatment at an outpatient community mental health setting. And we can see here with the inconsistency scales, they're pretty close, both men and women, to the general population mean. Of course, if any of our comparison group produces scores that are the same as the normative sample, they're going to have a mean of 50 and a standard deviation of 10. So to the extent that the means and standard deviations deviate from 50 and 10, that represents a difference for this particular comparison group, where we see a fairly sizable difference. The first fairly sizable difference is on the F scale, with men and women both scoring about 2 standard deviations above the general population mean. T-score 70 would be 2 standard deviations above the general population mean of 50, with a standard that has a standard deviation of 10 associated with it. And what this represents is the fact that scores on our over-reporting scales, including the F scale of the MMPI-3, are confounded. There's a confound of genuine psychopathology. Individuals experiencing psychopathology do score above average on the in frequency scale F, and also on some of our other over-reporting scales. And of course, that is embedded in the interpretive guidelines and needs always to be considered as one of the reasons why someone may score at a moderate elevation level, but once the scores get much higher than that on these over-reporting scales, then there is going to be, based on the interpretive guidance, some conclusion that there appears to be over-reporting present in a sample. So this gives us the perspective on, well, what do we typically find in mental health outpatients on these validity scales? And you can see here the women score a little bit higher than the men on FS, FBS, and RBS in the case of the outpatient community mental health sample. Turning to the substantive scales, we can see that we have some substantial elevations, as we would expect in a mental health setting. And at the higher order level, the highest scores are on the emotional internalizing dysfunction scale, indicating that in terms of the clinical presentation, there is substantial presentation of difficulties in the domains of mood and affect, fairly broad domains of mood and affect that are represented by the higher order EID scale, and at the RC scale level, we're seeing elevations on the three scales associated with EID, the three RC scales, namely demoralization, RC2 low positive emotions, and RC7 dysfunctional negative emotions. And again, this gives us an indication of, on average, what do we typically see in these settings. Now you can see that the standard deviations are larger than 10, so there's more variability, and indeed some individuals in this sample score quite a bit above the mean on these scales, and there is that broader range of scores, which also would be expected in a mental health outpatient sample. Turning to the somatic and cognitive scales, the highest score for our mental health outpatient sample is on cognitive complaints. And among the internalizing specific problem scales, anxiety-related experiences, where we do see a 7-point difference between the women and the men on this scale, that's reflective of various experiences associated with anxiety, including possibly features of post-traumatic stress disorder, although we obviously don't diagnose any specific disorder based on MMPI-3 scale scores alone, and also elevations on some of the other internalizing scales here as well. On the externalizing scales, nothing in particular stands out for the mental health outpatients. Clearly, this is a sample where we're going to see more elevations and variability in the internalizing than in the externalizing domain. We'll point out that on these two interpersonal scales, scores are a little bit below average, and on the Psi-5 scales, which are measures of psychological constructs associated with features of personality disorders, we're seeing elevations on the scales associated with cluster C personality disorders for both men and women, and again, that difference on the disconstraint scale, with men scoring higher than women on the disconstraint measure of the Psi-5. Okay, turning to the next sample, we have a police candidate comparison group. Police candidates are a good example of a type of assessment where having a comparison group can be very useful, because this is obviously not a traditional mental health setting, and there are certain features of this types of assessment in terms of who winds up being referred and all of the hoops and hurdles that they have to go through before they even receive a conditional offer of employment and are referred for a pre-employment psychological evaluation. And of course, the demand characteristics of someone who is being assessed in the context of an evaluation for a position that they are very interested in obtaining. Now, again, we use combined gender comparison groups for any kind of employment-related setting. And in this case, we have a large sample of over 2,000 individuals, equal number of men and women in this combined gender sample of individuals who were assessed in the context of a pre-employment evaluation for the position of police officer. So again, these are all individuals who've already gone through background investigations and any kind of a non-psychopathology focused assessment designed to identify them as potential candidates who have received conditional offers of employment from the agency that's referring them for the evaluation. And it is by no means a random sample of the adult population of the United States, and we can see some very significant differences between their scores. And of course, again, the normative sample would have a mean of 50 and a standard deviation of 10. The first thing that we see is that they score quite low on the inconsistency scales, CRIN and VRIN, which means that they were paying very close attention and were very deliberate in their approach to the evaluation, which again is certainly what we would expect for someone tested under these circumstances. And we also see elevations on the underreporting scales, which again, given the demand characteristics to appear favorable, that would likely account for some of this. elevation that we see on the underreporting scales, but also some of the other confounding factors for interpreting scores on L, for example, being raised in a more traditional background is associated with about a 5 T-score point higher score on the L scale. And the K scale, the primary confound for K is good psychological adjustment. So people who are better adjusted than average score above average on the K scale. Now, in a clinical setting, having someone score high on a measure that's associated with good psychological adjustment in all likelihood points to underreporting. But in the context of a pre-employment evaluation, we need to be mindful of the fact that, again, this is not a random sample of the population. These are all individuals who have gone through very thorough background investigations and have gone through other selection processes before they're referred for the evaluation. So it is a better adjusted than average sample that winds up presenting for a pre-employment evaluation. The other thing to be mindful of is that we have very small, quite a bit smaller standard deviations compared with the general population standard deviation of 10. And as a result, for example, if we look here at the CRIN scale with a mean of 39 and a standard deviation of 5, that means that a T-score of 49 on CRIN for a law enforcement candidate is 2 standard deviations above the comparison group mean. So again, that's something that we're going to be focusing on a little bit later when we look at the case examples. Looking at the substantive scales, again, not surprisingly, given all of the features that I've just described of this population, the means are quite a bit below the general population mean of 50, and the standard deviations, again, are going to be much smaller than that standard deviation of 10. So if we look again at the EID scale in this case with a mean of 37 and a standard deviation of 5, a T-score of 47 is 2 standard deviations above the mean for the police candidate comparison group. Looking at the specific problem scales, the one I wanted to point to here, in general, we see similar findings, below average means and smaller standard deviations. The one exception is the compulsivity scale, where this is a measure that at clinically elevated ranges identifies someone who engages in compulsive, repetitive checking behavior, tends to be rigid. At a T-score of 47, that's not an indication of proclivities towards compulsive behavior. It most likely reflects the fact that someone assessed in the context of a pre-employment evaluation is going to tell us that they are careful and check their work, so to speak. This isn't something that I would interpret as clinically meaningful in itself, but just to be mindful of the fact that on other scales, we're going to see lower scores. Compulsivity is going to be much closer to the general population mean in the context of a pre-employment evaluation, at least as we see here with police candidates. And we'll see shortly that that's also the case with other pre-employment samples as well. With the externalizing scales and the interpersonal scales, what I'll mention here are 2 additional scales, self-importance and dominance, where the police candidates score fairly similar to the general population. Means right around 50, standard deviations not quite at 10, but larger than we find for the other samples. And again, it's good to know that because we generally expect scores to be below average, below 50 on scales for pre-employment assessments, but not for self-importance and for the dominance scale. And here finally we see the Psi-5 scales. Nothing in particular stands out here. Now what I'm going to show you on the next set of slides is all 4 of our pre-employment public safety pre-employment comparison groups. So the police officers that we just looked at, correctional officers, a sample of 536, 256 dispatchers, and 220 Firefighters, again, all of these are combined gender, so equal number of individuals identifying as men and women in each of these comparison groups. And what you're going to see in general here is that the similarities are quite remarkable across these four occupations. The one scale on which we see a little bit more separation is L, with our correctional officers having a mean score of 61 on L, and the dispatchers having a mean T-score of 54. So that's the largest difference that we see here. But otherwise, by and large, very comparable scores for the four public safety positions on the higher order and restructured clinical scales. Here's that compulsivity scale that I pointed out to in the context of the police officers. We see similar findings for the other public safety positions, also with the self-importance and the dominance scales for the other public safety positions, and quite comparable scores for the on the Psi-5 scales. All right, this is one of our recently added comparison groups, a sample of airline pilot candidates. So these were individuals who went through a pre-employment psychological evaluation in the context of an application for a position with an airline, a North American airline. You can see that we have a combined gender sample, again, because this is a pre-employment context, of 204 individuals, so 102 identifying as men, 102 identifying as women, and fairly comparable results to what we saw with our public safety candidate comparison group. So lower scores on the inconsistency scales, and higher scores on K, but not on L. This is one scale on which there's a little bit of a difference between the public safety candidates that we were just looking at and our airline pilot candidates. The airline pilot candidates score right at the general population mean of 50 on the L scale, but are above average. Given all the training and background that's required before you're even considered to be a pilot for a commercial airline, obviously that is a better adjusted than the average in the adult population. So this elevation or score on the K scale is not surprising or unexpected. As you can see, again, the standard deviations, except for the underreporting scales, are quite a bit smaller than the general population standard deviations. Looking at the substantive scales, as we saw with the public safety candidate samples, below average scores with lower standard deviations, smaller standard deviations. Same finding that we've seen with the other pre-employment samples for the compulsivity scale, right at the general population mean and comparable standard deviation. So again, just important to be aware of that. That doesn't say there's anything wrong with our candidates in terms of compulsivity, just that on that particular scale, they're going to score similar to the general population. And that's also the case for our self-importance and dominance interpersonal scales, and also for the activation scale. Again, this is well within, within normal limits. It is the slightly below the general population mean of 50, with a slightly smaller standard deviation as well. And nothing in particular stands out with regard to the Psi-5 scales for our airline pilot candidates. Another newly added sample is our sample of child custody litigants. And so here we have a sample of 266 men and 253 women with the child custody litigants. These are individuals who are undergoing psychological evaluation in the context of litigation related to child custody matters, usually in the context of a divorce proceedings. And we can see that, as we might expect, given the demand characteristics of child custody evaluation, we see above average scores on L and on K for this sample of child custody litigants, very consistent with previous research or research with previous versions of the MMPI with child custody litigants. the T-scores, the mean T-scores, fairly close to the general population mean on some scales, considerably below average on others. The standard deviations are larger than what we saw in our pre-employment samples. So there's going to be more variability. We're going to see more people scoring quite a bit higher than the mean for their sample or for that comparison group. And the highest score here is on RC6. Now, again, it's at the general population mean 50, but that is what we would expect now based on these data as a general normative rule for child custody litigants. As that means that if we see scores that are considerably above 50, certainly in the clinically elevated range, that's not something that we will attribute to being in the process of going through child custody litigation, because the average child custody litigant scores right around 50 on the RC6 ideas of persecution scale. Here are the findings for the somatic cognitive and the internalizing scales. Nothing in particular stands out here, or for our externalizing and interpersonal scales and the Psi-5 scales. Again, we get that difference between men and women, the men scoring higher than the women on the disconstraint scale. And then our next and final sample that we're going to look at, comparison group sample that we're going to look at for this presentation, are the disability claimants. So these are individuals undergoing a forensic evaluation associated with a disability claim, 499 men, 405 women. Not surprisingly, we're seeing some elevations on the over-reporting scales. Now, I should mention that all of these are valid to be included in a comparison group. MMPI-3 protocol has to be valid, meaning that we have scores below the cutoffs for invalidity on the inconsistency and the two over-reporting scales that can invalidate a protocol, F and FP. Now, the other thing to be mindful of here with our disability claimants is that, of course, a fairly sizable proportion of these individuals wind up being found to have significant psychological problems. So that, to some extent, can account for their elevations on the over-reporting scales, as might a proclivity to exaggerate or over-report symptoms, and we need to follow the standard interpretive guidelines for identifying at different levels of elevation on the over-reporting scales. They fall quite a bit higher than what we see here for the means, would be indicative of actual over-reporting rather than more likely reflecting some genuine psychological dysfunction. You can also see that we have a lot more variability. The standard deviations here, for example, on the F scale are 16 and 15 respectively for the men and women in disability claimants versus a 10 standard deviation in the general population. Looking at the substantive scales, we can see that not unexpectedly, the highest elevation is in the emotional internalizing domain. Many of these disability claims have to do with traumatic experiences, potential post-traumatic stress disorder, other emotional difficulties related to experiences leading to the disability claim. So that's an expected finding. On the RC scales, we're seeing elevations on demoralization, and RC1 is somatic complaints. And of course, that also is often part of the picture in a disability claim, as we also see indications or elevated mean score on the low positive emotion scale associated with depression-related difficulties in particular. Looking at our specific problem scales, somatic, cognitive, internalizing, it's the cognitive complaints that's particularly elevated for this sample of disability claimants, and anxiety-related experiences, again, likely reflecting the kinds of issues that are the focus of the claims made in these assessments. On the other hand, externalizing scale scores tend to be within normal limits among disability claimants. With the interpersonal scales, we see somewhat higher scores on some of our interpersonal functioning indicators, disaffiliatedness, and social avoidance in particular. And then finally, the Sci-5 scales, the two scales associated with emotional difficulties and possible features of cluster C personality disorders, also higher than average in this sample of disability claimants. Okay, so those are just some examples of our comparison groups that are available for the MMPI-3. For those who are not familiar with it, with what this looks like in terms of the reports, we have a score report and an interpretive report that you can add any of these comparison groups to and get the additional information. And what we're looking at here is a comparison group using the mental health outpatient, male mental health outpatients from a community mental health center. So this is an individual who was tested at a community mental health center. And of course, their actual T-scores tell us how their scores compare with the general population mean. The open diamond for each scale represents the mean for the comparison group. The shaded bars are plus or minus 1 standard deviation from the mean for the comparison group. And in this case, we have an individual who's scoring well below the mean on the CRIN scale. And the final numbers, the final bottom row of numbers with the comparison groups is an important one. It tells us what percent of individuals in a comparison group score at or below a test taker. These numbers are analogous to percentiles. They're not calculated exactly the same way, but they can be interpreted the same as percentiles. So we can see that in this case, we have an individual at the 4th percentile, so much more consistent responding for this test taker than what we typically see in a mental health outpatient. This was someone who was very meticulous, very cautious, particularly for a mental health outpatient in responding to the items of the MMPI-3, and that put them at the 4th percentile. So this is basically what the profiles look like. For item level information, we don't include in these slides the actual item numbers and content for test security reasons. But you can see that for critical responses and anywhere where we include item level information, we also report the percent of individuals, and S stands for the normative sample. So this person with a T-score of 72 on the suicidal death ideation scale responded to 3 of the items on the scale in the key direction. And we can see that the first of these items was answered true. That's an item keyed true by 22% of the normative sample and 43.3% of the comparison group of male mental health outpatients. So we do provide comparison group data at the item level. We're not focusing on that in this presentation, again, for test security reasons. All right, so let's take a look at some of our case examples. And the first will be that of a 19-year-old woman who was tested in a college counseling clinic at intake for mental health services. And again, the solid line connects her scores, her actual T-scores. The dotted line connects the means for the comparison group, shaded bars plus or minus 1 standard deviation from the mean. And we can see that this is a very typical set of scores on the validity scales for a mental health outpatient. In this case, we're using the combined gender sample of mental health, a college counseling clinic. So it's equal number of men and women in this comparison group, and her score falls right at the comparison group mean on the validity scales. When we look at start looking at the substantive scales, we see that on one scale in particular, she has a clinically elevated score on RC9, T-score of 72, whereas the mean for mental health, for college counseling clinic individuals seen in college counseling clinics is actually 50. And that places her T-score of 72 on RC9 at the 97th percentile. So this is a very uncommon finding, but obviously gives us an indication that there is some significant concern with regard to potential hypomanic activation and all of the features associated with an elevation on RC9. As we go through the rest of her protocol, we can see that she has a clinically elevated score on cognitive complaints, and it's just outside the standard deviation bar. It's at the 90th percentile for a mental health outpatient. She reaches the ceiling. These hash marks represent the highest and lowest possible T-score on each scale. So she's reached the ceiling on inefficacy, which means that by definition, she's going to be at the 100th percentile. No one can score above this ceiling. And we can see that she's also produced a clinically elevated score on self-doubt, although it falls within one standard deviation and is at the 80th percentile. That's still a clinically elevated score and one that needs to be interpreted accordingly. Also see an elevation actually at the ceiling on the impulsivity scale, one of our new scales on the MMPI-3 and on the activation scale. Both of these are associated with RC9, and so we're seeing further evidence of potential difficulties related to overactivation, overstimulation. There was also an elevation on cognitive complaints. We might also consider possible features of ADHD in a protocol that has these scores, but it seems to go beyond that with the elevation that we saw on RC9. We can see that she has relatively low scores on self-importance and dominance. On the Psi-5 scales, she pretty much tracks the mean except for the aggressiveness scale. She's below average on this scale, and that's associated with a tendency to be more passive and submissive in interpersonal relationships. You can see here she's at the 16th percentile for this population on the aggressiveness scale. Turning next to a child custody litigant case, a 33-year-old woman who was assessed in the context of child custody evaluation. So now we're using our child custody litigant comparison group. We can see that on the validity scales, one thing that stands out is that she's a little bit below the mean on the underreporting scales. Again, there is a demand characteristic towards underreporting in this type of evaluation. She's not substantially below the mean, but we'll certainly want to take note of that. She does have a clinically elevated score on RC2, low positive emotions associated with anhedonia and lack of positive emotional experiences. She's at the 99.6 percentile for a child custody litigant on this scale, so that's a substantial elevation, coupled with a very low score at the floor, the raw score of 0 on RC9, lack of energy, and other features associated with that would be part of the interpretation. On the self-doubt scale, low self-esteem, poor self-concept. She's clinically elevated. That's a rather uncommon finding for a child custody litigant. She's at the 97th percentile on the scale here in this example. Very low score on the cynicism scale at a raw score of 0. 26% of female child custody litigants score that low on the cynicism scale, and that's associated with a tendency towards perhaps being somewhat naive insofar as interpersonal relationships are concerned. And she's at the cutoff of 65 on introversion, low positive emotionality, which is associated with features of some cluster C personality disorders. And again, that's an uncommon finding for a female child custody litigant. Here we're looking next at the protocol of a male child custody litigant. In contrast with the case that we were just looking at here, we do see higher scores on the underreporting scales. In fact, he's at the ceiling. That's the highest possible T-score on the K scale, claiming to be very well adjusted, uncommonly so for a child custody litigant, and also elevated on L, denying minor faults and shortcomings, again, at a level that we don't typically see in child custody litigants. Also very careful, cautious, and deliberate in his approach to making sure not to contradict himself when responding to the MMPI-3 items. RC4 approaching a T-score of 65 at the 95 and 95th percentile for a male child custody litigant. On the other hand, with the effort to appear well-adjusted emotionally, very low scores on the interpersonal scales. In fact, a row of 0 raw scores with the exception of a 2 on the compulsivity scale. And that may very well be a reflection of some underreporting in this case. Elevation, clinically elevated score on juvenile conduct problems, so it does acknowledge a history of juvenile misconduct and approaching clinically significant elevation on the self-importance scale. This is a scale that at this level is associated with the possible presence of features of narcissism, narcissistic personality disorder. Again, we're not indicating a diagnosis, but definitely some features that need to be looked at along with all the other information that's available to the assessor. And disconstraint, not clinically elevated, but substantially higher than we typically see in a male child custody litigant at the 93rd percentile. Next, we'll take a look at a police candidate, a 23-year-old male police candidate. In this case, scores on the underreporting scales lower than what we typically find among police candidates. He's at the 10th percentile on the K scale, raising at least the question of why he didn't try to look a little bit better. And maybe here's the answer: a clinically elevated and very substantially so T-score of 76 on RC9. Very uncommon, obviously. No member of the police candidate comparison group, none of the 2,036 individuals in the police candidate comparison group score higher than this on RC9. Obviously, a very substantial red flag. Also have a associated elevation on the activation scale at the 99th percentile, self-importance at the 95th percentile. So there definitely would be some red flags indicated here in this MMPI-3. Next, we have a protocol for a 30-year-old airline pilot candidate using our recently added airline pilot comparison group. She's about as prototypical as they come in terms of scores being very close to the comparison group mean. Nothing stands out on the substantive scales. We can see that little blip here on compulsivity that we talked about earlier. That's common. That's not at all an indication of any potential problem in this case. Again, scores all well within normal limits and within the range that we typically find in airline pilot candidates. This would be a very clean-looking protocol. Here is another example of an airline pilot candidate, a 31-year-old male. Now, here we are seeing some deviations from what we would expect to find in airline pilot candidates. Not at all common to see a score this high on the TRIN scale, some inconsistent responding in the true direction at the 99.5 percentile here. Also more inconsistent responding than we tip. Doesn't invalidate the protocol, but it would certainly raise the question of why this individual wasn't being more careful in the context of a pre-employment evaluation. Scores within normal range, no clinically elevated scores on the higher order or the RC scales, but RC9 is at the 96th percentile. When we go to the specific problem scales, we do find some clinically significant elevations and some unexpected ones. Behavior restricting fears associated with excessive fearfulness that could limit the individual's comfort zone and would indicate some risk aversion, which we would potentially be quite concerned about in the context of a pre-employment evaluation of a airline pilot candidate. Here we see the compulsivity score now is in the clinically elevated range, well outside the standard deviation bar for a airline pilot candidate. Also, the worry scale is clinically elevated, a proclivity to worry and ruminate about possible concerns. So obviously these would be some scores that would raise red flags and would require further consideration insofar as this individual's suitability for the position of airline pilot candidate. Final case example that we'll look at is a 42-year-old non-binary disability claimant. So we're going to use the combined gender comparison group for this non-binary individual. We can see that their scores on the validity scales are fairly much within the expected range for a disability claimant, a little bit above the mean T-score of 66 at 75. That's the initial threshold for beginning to interpret scores on the F scale, but obviously we would need additional information about the individual and their functioning to know how to interpret that. We do get the added context that this is not atypical for a disability claimant to score that high on the F scale. We're seeing elevations on emotional internalizing dysfunction, demoralization, RC2 for this disability claimant, and elevations on some of the scales related to stress and worry and a sense of inefficacy. Very high scores on the interpersonal scales, disaffiliativeness, social avoidance, shyness, all at the ceiling, meaning that you can't score any higher than this. Whether this has anything to do either with a disability claim or perhaps some pre-existing conditions that predate whatever the experience was that led to the disability, evaluation would need to be considered in this case. And at the ceiling on the introversion low positive emotionality scale, which is associated with features of cluster C personality disorders. We have one more case, which we'll go through, and then we'll come to some final observations. So 51-year-old bariatric surgery candidate, you can see that on the validity scale, she's within normal limits. Also on the higher order and restructured clinical scales, nothing stands out. Fairly clean protocol for a bariatric surgery candidate. These assessments typically are conducted in order to see whether there are any mental health concerns that need to be addressed prior to or after, depending upon the findings, bariatric surgery. She is elevated on impulsivity, so tendency towards some non-planfulness that the bariatric surgery team would want to be aware of and take into account in making plans for this individual and their pre and after care, and within normal limits on the Psi-5 scales. So some key points and takeaways for this webinar on the comparison groups. Comparison groups can be very helpful, and they can help refine MMPI-3 interpretation. But one important point is that they're not necessary. So it is possible to interpret an MMPI-3 without comparison groups. Indeed, the interpretive guidelines in the Manual for Administration, Scoring, and Interpretation, and the interpretive report for clinical settings do not take comparison group findings into account. This is some added information that can be very helpful, but it's not necessary, it's not needed in order to interpret the MMPI-3. The other important point that I want to emphasize is that comparison group elevation. So the fact that a comparison group may have a mean score that's in the clinically elevated range doesn't mean that if someone scores in that range, that problem is not salient. And a good example of this is that the mean T-score for our community mental health outpatient sample on the suicidal death ideation scale is 58 for men and 59 for women, which is actually interpretable. The cutoff for interpreting suicidal death ideation on the MMPI-3 is a T-score of 58. And so if a mental health outpatient has a T-score of 58, just because other mental health outpatients also tend to score that high, doesn't mean that we don't take note of that clinically elevated score. And of course, on this scale, indicating potential risk for suicide or self-harm. And so we don't ignore a finding just because a comparison group tells us that other individuals or that most individuals in the sample have similar problems or concerns. One thing I didn't touch on but wanted to mention is that you can also create your own comparison groups with the software that's available to score the MMPI-3 from Pearson. We call these user-defined or custom comparison groups. And as long as you have 200 valid cases representing a population that you work with and that you would like to have a comparison group or use your own custom comparison group with, you can use the software to generate, and there's information in the user's guide for the MMPI-3 software-based reports on how to generate your own custom comparison groups. This can be helpful for settings for which we don't have at this time comparison groups, or if you work with a very unique population for which we're not likely to have standard comparison groups available. You can create your own custom comparison group and then print the results in a score report or an interpretive report and use them exactly the same as you do with any of our standard comparison groups. Now, we do have some setting-specific interpretive reports that take comparison group data into account. Remember, I mentioned earlier that the clinical interpretive report does not incorporate comparison group data in the interpretation. You can include a comparison group in the profiles, but it won't alter the interpretation. For our police and public safety interpretive reports that are available for the MMPI-3, we do take comparison group findings into account. They are incorporated in the interpretation, and that will also be the case in future interpretive reports. The next one to be released is for use with spine surgery candidates and spinal cord stimulator candidates. And so that interpretive report, which will be released later in 2024, will take into account comparison group data, and we will be doing that with additional interpretive reports as they become available. So that's the material I wanted to go over. I think we might have a couple of questions that Ben is going to come back and let me know about, and I'll answer.
Yes, thank you so much. A lot of great detailed information and case studies. I always come away from these understanding quite a bit more about this assessment tool. And you are correct. We do have a couple of quick questions I think we can get through. The first one up here is, might you have a suggestion as to the appropriate comparison group for a kidney transplant candidate?
Yes, so that's a good example of a type of assessment for which we don't at this time have a comparison group. We are interested in and are seeking data, and I'm in conversations with some individuals who do assessments in transplant of candidates for transplants, kidney and other organs. So for now, the thing to do is to just interpret the scores as you would in a regular clinical assessment following the standard interpretive guidelines. Obviously, when you're doing a pre-surgical evaluation, there are specific questions to be addressed that will be helpful once we do have an organ transplant comparison group available. But at this point, you would just use and rely on the general interpretive guidelines for the test.
Excellent, thank you. This last one's kind of a two-parter, but I think it goes together. Obviously, you touched on the 19 comparison groups that we were able to release earlier this year. Are there any more that are close to being completed that we can look forward to in the near future? And then in addition to that, are there any you're looking for more cases, perhaps in future releases, that people might be able to reach out for you if they're able to access that population?
Absolutely. So yes, we are working on additional comparison groups. You may have noted that we don't at this time have a pretrial comparison group for forensic settings. We're collecting data, and if anyone attending today or watching this recording has cases that they are able to contribute towards that effort, please contact me. My email address is on the first slide. We also, at this point, don't have and are working to collect data for psychiatric inpatients. We don't see anywhere near as many assessments being done with psychiatric inpatients at this point, with the exception of forensic cases, in part because people don't spend very lengthy periods of time as psychiatric inpatients as in comparison with the past, but we are interested in and are collecting data for that purpose. Organ transplant candidates is another example. Chronic pain is another sample that we're working towards. And again, if anyone has access to data for other populations that you think might be of general interest, please do contact me, and I'll be very happy to discuss the possibility of using those data and developing future comparison groups for the MMPI-3.
Excellent. Well, that's all we have for today. Thank you so much for your time.
Thank you, Ben, and thanks everyone for watching this webinar.